Okay, it is 9:01. I'd like to welcome everyone to our Perspectives in Telehealth Policy webinar, Where We Are and What Comes Next. My name is Ray Wiesek. I am the Director of Policy and Advocacy with the American Urological Association. I am also the Urology Telehealth Task Force's liaison for the AUA. And we have a fantastic panel this morning. I'm really excited to bring this to you. But before we get into that, I just want to do a couple of housekeeping items. Adina, if you go to the next slide, please. So for our panel this morning, we have a number of topics that our panelists will speak about, and we will hold all questions until the end. However, if you do have a question, there is a chat box where you can type your question. Again, they won't be asked until the end of the panelist session, but we do have a large amount of time scheduled for Q&A. So please type those questions into the box, and then they will be asked at the end of the panel. If you'd like to continue this discussion on Twitter, we are using two different hashtags, AUA advocacy and hashtag telehealth. And then if you're having any sort of technical difficulties with the webinar, you can email Kim Nelson at knelson@auanet.org. Next slide, please. I just want to speak very briefly about the AUA's telehealth priorities and our Urology Telehealth Task Force. Our Urology Telehealth Task Force is chaired by Dr. Aaron Spitz, who's one of our panelists. It's been around since 2016, so the AUA has actually been interested in telehealth for some time now, before the pandemic and obviously during the pandemic. We have developed in the last year and a half several priorities around telehealth, specifically around the audio-only, payment parity, originating site requirements, and virtual supervision. For audio only, our main concern is bandwidth. Many of urologic patients that our physicians see don't have access to a large amount of bandwidth, so they're not able to have a simultaneous virtual visual and audio visit, oftentimes using a telephone as their only option. And so we want to preserve that benefit following the public health emergency. Payment parity is another major issue for the AUA, mainly for the fact that without proper reimbursement for telehealth visits, because those visits require the same amount of medical know-how and knowledge as an in-person evaluation management type visit, we would hope that the payment would be similar to those in-person visits. Originating site requirements, we do really believe, and thankfully many members of Congress also believe, that eliminating the originating site requirement is a huge benefit for ensuring that patients who need to see a specialist or other new physician can do so without having to visit their office in the first place. And then virtual supervision of both residents and also staff has been another major benefit for many of our members. We'd like to preserve that following the public health emergency. The AUA has been actively involved as well. We have been meeting with the Government Accountability Office, as well as with CMS, providing data to those two different agencies, both on the amount of urologic visits that are utilizing telehealth, as well as just the trends in utilization. We find that to be very helpful for those agencies, especially when we get into rulemaking. We were also very happy to see in the most recent version of the Medicare Physician Fee Schedule for calendar year 2022, that CMS defined the term home, although it's still very flexible. We at least now know that a home can be both a person's actual abode, as well as a tent, a temporary lodging such as a hotel, and if that patient is leaving their home to go to run some errands, for example, while using their cell phone, that the visit does not have to end. So we're very thankful for that. The Urology Telehealth Task Force is continuing to engage where they can. We'll hear more about that from our physicians on this call, but we are very thankful for them to being on. And with that, I'm going to move to the panelists. So Adina, next slide, please. I missed one, there we go. So our panelists this morning, as I said, are very well-versed experts in the field of telehealth. We have Dr. Eric Kirschenbaum, who's a Urology Telehealth Task Force member, Rachel Solomon, who is a member of the Cancer Support Community, Dr. Aaron Spitz, who is our chair of Urology Telehealth Task Force, and Chris Ademick, who is with the Alliance for Connected Care. And I'm going to give each of the panelists a moment to introduce themselves, explain why telehealth is important to them, and just talk a little bit about how they feel about telehealth. So starting with Dr. Kirschenbaum, please.
Good morning, everyone. Thank you for having me. So just a little bit of background of my role in kind of the telehealth universe and how I'm incorporating into my practice. So I'm in my third year, entering my third year of practice. I'm in private practice with a large group in Chicago called Euro Partners. And while I dabbled in telehealth before the pandemic, once the pandemic hit, that's where my telehealth practice expanded. And so currently I am integrating both new patient and established patients into my practice and looking to kind of extend my reach for both new patients and established patients. And my second area of focus is asynchronous visits, and seeing if we can incorporate the asynchronous visit into the urology practice. And then as my role as a task force member, just advocating for telehealth coverage and being an active member on that committee.
Thank you, Dr. Kirschenbaum. Rachel?
Thanks, Ray. Firstly, I first want to thank the AUA for convening this panel this morning and for the opportunity for the cancer support community to participate. I'm Rachel Solomon, and I'm the policy director at the Cancer Support Community's Cancer Policy Institute. Very quickly, I just wanted to share some information about the cancer support community for those that may be unfamiliar with the organization. We are a global non-profit network of 175 locations, including CSC and Gilda's Club centers, hospital and clinic partnerships, and satellite locations. And yearly, we deliver about $50 million in care in free support and navigation services to cancer patients and families. We also conduct cutting-edge research on the emotional, psychological, and financial journey of cancer patients through our Research and Training Institute. And CSC's Cancer Policy Institute that I'm a part of brings together the patient voice, patient advocates, and policy experts to ensure that the voice of the patients and their loved ones play a central role in federal and state legislative, regulatory, and executive policymaking. So our focus at CSC is always on the patient and how we can work towards a healthcare system that is truly centered on the experiences, preferences, and values of cancer patients and their loved ones. And we look at telehealth and telemental health services through that patient-centered lens as well. So as Congress, CMS, state, and healthcare plans look towards the future of telehealth and begin to reshape telehealth and telemental health policies, it's really important that the patient perspectives be incorporated to ensure that policymakers fully account for the needs of all people, including those with cancer and other serious illnesses. We also really must seize this opportunity that we're at to leverage telehealth, telemental health services in a way that breaks down unnecessary barriers to care and advances health equity in the healthcare system. It's really critical as we talk about telehealth and telemental health and the future that we bring along every community in the creation and the growth of telehealth.
Fantastic. Dr. Spitz? You're muted, Dr. Spitz.
Of course I did that. As the chair of the Telehealth Task Force, you'd think I'd know how to unmute myself on a teleconference by now. But it's an honor to be here. The Telehealth Task Force is the body within the American Urological Association that is tasked with organizing telehealth resources for our urologists and our patients. And we have been busy doing this even before the start of the pandemic. And urology is one of the leading specialties amongst all the specialties in innovating and adopting telehealth. As such, we have been able to generate a white paper, which is a guideline for all things telehealth for our urologists, but it's also been quoted and repurposed by other specialties over the years. We've also engaged very directly with legislators and government agencies, as well as agencies involved in also generating their own white papers and their own important contributions to this whole universe of telehealth. And so urologists and the American Urological Association has been very integral in influencing and trying to continue to influence the development of telehealth policy to maximize access for patients and maximize the ability of our urologists to understand how to do it and to meet the patients where they live in their homes. It's been very exciting and it's been very important. The pandemic accelerated the implementation and adoption of telehealth, in my estimation, by no less than 10 years. And we are very very much aligned with the concept of continuing access to telehealth at the level that it currently exists, or even greater, even after the end of the public health emergency declaration and the end of the pandemic.
And last but certainly not least, Chris.
Hello, everyone. Chris Adamick with the Alliance for Connected Care. The Alliance is a telehealth advocacy organization here in Washington, D.C. We bring together large health systems, leading technology vendors, large employers, health plans, and others who advocate for greater access to telehealth in Medicare, but also in other markets. So we have a long history in this space, which I won't go into too much, but in the last couple of years, some of our top things have been convening the task force on telehealth early in the pandemic. That followed us being, to my knowledge, one of the first national organizations to call for telehealth as a response to COVID-19. And we've been working on many legislative vehicles in many markets since, and working to bring our members and our advisory board together, and also really pleased to work with AUA in this work as well. So I'm happy to get into some of those details later and stop here.
All right, thank you to all of our panelists. Before I move on to our first question, I just wanted to note, one of the items I forgot in the housekeeping section is what we do after we have this discussion. What are kind of the things that patients who are listening to this call or providers listening to this call can actually take action on? I just want to note that the AUA has actually had an action alert for the Connect Act, which I am sure we will talk about during this panel. And when we do a survey that follows up on this, we will share our action alert on that, as well as any of the other information our panelists want to share as well. So I just want to kind of note that for everyone. Dina, next slide, please. And so with that, we move on to our question section here. And this is a question for all of our panelists. How do you compare patient access, quality of care, and outcomes with telehealth before and since the pandemic? Obviously, there's been a huge change. There's been a massive amount of data that's been collected from the pandemic, and we're still kind of sifting through it. But really, what have the main differences been?
I'm happy to kick that off. Similar to what Dr. Spitz was saying in his introductions, we know that obviously before the pandemic, telehealth utilization was quite low. I think in 2019, it was only a little over 10% of people across the US had used telehealth. But telehealth has long been an important care delivery method for improving access in underserved communities, particularly in rural areas, in areas with limited access to primary care services. But it's really was the pandemic that illuminated how telehealth, including telemental health, helps to reduce gaps in access to services and care, including access to primary care and as well as for specialized providers when in-person visits were, of course, not a safe or feasible option. Like Dr. Spitz said, in just a few months, telehealth grew leaps and bounds overnight, basically leaping ahead those 10 years. And we saw that telehealth usage grew significantly. So at the cancer support community, we wanted to hear directly from the cancer community about how they feel about telehealth. So in order to do that, soon after the public health emergency, we launched a longitudinal COVID-19 and cancer patient survey to understand the ongoing impact of COVID on the cancer community. So that longitudinal study is now in its fourth wave of data collection, but our survey had found that nearly 80% of respondents had reported engaging in telehealth visits during the pandemic in 2020. And we saw that the most common type of appointments for those sessions were general medical appointments, but over half of the respondents had engaged in cancer-related care appointments via telehealth. We had one patient share with us something that really stuck out to me about why we're doing this work, why we're talking about it this morning, why this is so important. Because she had shared with us that for someone who is high risk and immunocompromised, going in person during times of pandemics, it's quite frankly terrifying. I spent 5 years of my life fighting to stay alive, and I don't want to compromise my health in any way because I have to go to the doctor. So again, that's just something that really always sticks out to me about why we are doing what we're doing, and that is for the patient. In cancer care, studies have shown that telehealth appointments, in addition to in-person visits, can provide beneficial mental health and symptom relief to patients experiencing certain types of cancers. And because of that, that was another big piece of our COVID-19 and cancer survey goals, is to understand the impact of COVID on the psychosocial well-being of cancer patients and survivors. We know that the COVID-19 pandemic continues to pose a threat to mental well-being, both in the general population as well as in the cancer population. So we had found from our survey that COVID-19 appears to have a greater impact on those in active cancer treatment, as they've reported more anxiety and more depression. And because of that, telemental health services plays a really important role in delivering mental health care to people across the country. And I think it's really important that while the pandemic itself has fundamentally changed the way that we think about how it's best to deliver healthcare, it's really critical that we think about telehealth not just in a way to preserve continuity of care during public health emergencies, but rather a critical part of a modern technological healthcare system, because we know telehealth is here to stay and times are changing and the healthcare system needs to keep pace with that change. And so I look forward to talking more about that and those patient perspectives as we continue on in our panel this morning.
So I would like to comment that prior to the pandemic, telehealth was in process, and it was being done in rural areas. It was being done in the urology world, probably more with pediatrics than perhaps any other specialty, because of the limited nature of the availability of pediatric urologists. And surgeons were doing it in sort of pilot projects. At the Mayo Clinic, there was a project where they studied the satisfaction of delivering telehealth both to prostate cancer patients remotely and then even post-operatively for follow-up. And the data showed that the quality of care with telemedicine for urology patients was actually very good. The patient satisfaction rates were high. The ability to accurately diagnose and accurately make decisions and provide care was great. And the providers themselves also gave high satisfaction scores. So through these limited pilot programs, we knew that we could deliver quality care with telemedicine, but the adoption was very limited. There was very few doctors who were offering it. And then during the pandemic, the adoption of telemedicine was basically required for the continuation of healthcare delivery, especially during the shutdown periods. And so by the peak of the pandemic, about 77% of urologists across the country were now providing telemedicine care to patients. But as the pandemic has sort of ebbed and flowed, many patients have returned to in-office. And so the amount of telemedicine occurring is a lot less. However, the platforms are now in place. And so many urologists, even though they don't conduct as much telemedicine as they did at the peak of the pandemic, continue to provide it. In our practice, for example, at the peak, we were doing almost all telemedicine and only seeing very urgent patients in person. And so I had a half day a week in which I was going into the clinic. Now I do a half day or a couple half days a week of telemedicine, and the rest of the time I'm going into the clinic. But we have the ability to scale up and scale down. And I personally have observed that the quality of care and the outcomes with telemedicine in my practice of 11 people who all do telemedicine as part of their weekly schedule has been very, very good. We haven't done a formal study within our practice, but those kinds of longitudinal studies are underway. And I believe that the data will show that telemedicine does provide good outcomes. And we know that we can provide large scale access now.
I'll just add a couple things. So I think in a very short amount of time, we've successfully integrated this brand new technology into our clinics. And really, my biggest challenge and what I feel like we've done is educating our patients. The first time that I talked to a patient about telemedicine or scheduling a virtual appointment, they really looked at me cross-eyed. I mean, we're in urology. In urology, we have an older population who's less technology savvy. And now I don't think there's a patient, whether he's 95 years old with an iPhone or 18 years old, they know what virtual visits are. They know what telemedicine, they've been educated, and it's part of their medical care. And I think we've successfully integrated kind of that knowledge base into their realm. You know, in terms of quality, I think this is something that we need to constantly be looking at. In medical school, we learn how to use a stethoscope and an otoscope, but we don't really know how to integrate telemedicine into our practice. We weren't taught that, and we were forced to do that very quickly. And I think we've done a very good job, but I think we have to constantly be looking at and making sure that we are providing the same quality of care in person and virtually, and understanding that some patients will benefit more from the virtual visit, and some patients will benefit more from an in-person visit. So I don't think we can be fooled that telemedicine is the end all be all of everything. It's just a great tool that we have at our expense to enhance the care of our patients.
Yeah, I'd like
And then
to
oh, go ahead.
just chime in one more time. You know, the reason that telemedicine was offered in such a very limited and restricted fashion prior to the pandemic was because Medicare restricted it severely. There was very strict criteria of who could receive telemedicine care. They had to be in a rural area or a very underserved area with specific designations. They had to receive that care in a specific kind of a facility. And with the pandemic, Medicare issued waivers that took away all those restrictions and then allowed it to be conducted. So it wasn't necessarily out of a lack of interest, but actually due to very narrow regulatory restrictions prior to the pandemic.
And then I want to weigh in at kind of the 10,000 foot level, which is maybe both applicable for urologists, but also others. So we've talked about access here. As noted, access to telehealth is an expansion of access for patients. So that's people that are homebound or frail or have other reasons that they can't make it to the doctor, people that are in rural areas where there are clinician shortages, many opportunities to increase access. That has downstream implications. We think we have more care when patients need it, ideally preventative care and other treatments that'll keep people out of the hospital. Still looking for more data on that point, but is an important development that we think telehealth has an important role to play in. As others have noted, quality and outcomes, we are seeing some really exciting initial studies, which are great. There's still lots of data to collect, though, just to have a full understanding of everything that's happened during the pandemic. I also want to emphasize efficiency. There is certainly an efficiency benefit from telehealth. Not to say that it's easier, but one thing that we've seen is a lot fewer no-show visits in the telehealth space. So clinicians' time is less likely to be wasted by a patient who doesn't make their appointment in a telehealth arrangement than it is in an in-person visit. And then finally, I think one of the other silver linings that we've seen from the telehealth expansion during the pandemic, and I think I heard this from a couple of the doctors here, is a little bit more flexibility for clinicians in the delivery of care. We have lots of conversations around burnout among medical professionals. We've heard lots of relatively positive stories around people that are able to help some patients from home in the morning, go into the clinic, help patients there, but work around their personal schedules a little bit more in a way that helps relieve some of the burden that medical professionals obviously hold. And another really positive example, some of our health systems have use telehealth as a way to help mothers both before and after having children transition back into the workforce. It's a nice way to create flexibility for medical professionals who are delivering care. So those are my kind of thoughts I'll add on to that.
Fantastic. Next slide, please. So this question is for Dr. Kirschenbaum, and it is kind of a two-part question. I'm going to ask it as one, and obviously the slide's up. But how has telehealth improved patient care? I think we kind of talked about that a little bit in the previous question. But the second part is how are providers incorporating it into their patient care plans? And I think that would be an interesting thing to hear from you.
Yeah. So I think telehealth has improved patient care tremendously. When you ask that question, there's one patient that kind of came to mind who I follow. He's this 19-year-old kid who's wheelchair bound, disabled, has to do intermittent catheterization, has a lot of urinary tract infection issues, and he's cared for by his grandparents, actually, who both over the past year have developed their own medical issues. And my ability to conduct telehealth visits, I think, has in many ways improved his life, improved the life of his family, where it was a huge undertaking to get him to our clinic, requiring transport. His grandparents had to take time off of work, so it was a huge undertaking. But now I see this patient probably twice a month. I'm able to manage his intermittent catheterization. His parents are able to, or his grandparents are able to bring in a urine sample, not take it when we need one. So I'm coordinating his care virtually, where it takes him maybe 5-10 minutes of his life to have the visit, where before it would have taken 3 people's afternoons or mornings, and I'm really able to care for him completely virtually and have him come in kind of once a year. So I think that's just an example of how a single patient can be improved by expansion of telehealth. And then how are providers incorporating this into their patient care plans? I think this is evolving. And while at the beginning of the pandemic, all urologic care, or almost all urologic care, was done virtually, now I think clinicians are really finding their niches. My niche is I'm seeing established patients and new patients, and there's specific disease processes that I'm using for my established patients. For example, enlarged prostate, I think that's a great population that after that initial visit, that I can follow them virtually. Stone disease, does every patient who's had some sort of imaging for their stone follow-up, do they all need to come to the clinic? I don't think so. A lot of them can be managed virtually. Low testosterone patients. I think the list goes on in terms of the established patient. And then in the new patient, I think there's also a real opportunity for patients to establish a real relationship with their physicians. In my practice, I have a reconstructive urology practice where a lot of the providers are referring their patients to me. And a patient who lives 30, 40, 50 miles away is able to schedule a virtual appointment with me. We're able to spend the time. I'm able to educate them without them having to make that trip. And when they need that human touch, when I need to do a procedure, then obviously that has to be in person. But I think as clinicians, we're doing a good job incorporating both the virtual visit and the in-person brick and mortar. And it's really having a significant impact on patients' lives.
Does anybody else want to comment on this question?
Sure. I'd like to point out that in my practice, I'm in a suburban setting. And so even though I serve at a national level with regards to the implementation of telehealth, and there's so many amazing examples, such as Dr. Kirschenbaum pointed out, of how we can reach people who have severe mobility limitations or geographic restrictions, I actually use telemedicine for patients who live nearby and don't really have a lot of restrictions on their mobility. I specialize in sexual medicine and fertility, but the efficiency and convenience of telemedicine allows my patients to minimally disrupt their very productive lives. Normally, these are people who are often in the peak of their careers, and the time it takes to come and see a doctor during regular business hours usually results in missing a couple hours of work, if not more. And the ability to preserve people's professional lives while still allowing them to get timely access to care, I think is a huge benefit, not just to the individuals, but also to our community here, our local economy. And so even in the least sort of critical and least dramatic scenario, telehealth is helping patients and helping the community, I think, in a very important and profound way.
Yeah, I've had many patients take their visits in the car, take their visits in their office. So yeah, that lack of disruption in their lives is, I can't say enough about that and how much that improves their life.
And Dr. Kirschenbaum, to your point too, with the care team, you have these caregivers who are also spending, majority of their time bringing patients in who have mobility issues. I think that's a very point well taken. And with that, we'll move on to our next question. So this is a question for Rachel. What are patients saying about receiving care virtually? And this kind of goes to, dovetails with the previous question. And then how has telehealth improved patient satisfaction, if you have any information on that?
Yeah, so similar to what was just mentioned regarding, patient outcomes, virtual doctor's appointments can, of course, help to reduce those barriers, lack of transportation, the inability to take off work, mobility issues, finding childcare that may have traditionally prevented people from accessing in-person healthcare. In CSC's COVID-19 and cancer patient survey, we've found that the majority of patients reported that telehealth sessions, that they had a very positive impact on those appointments. They said they had reported that they experienced positive outcomes, had their healthcare concerns and questions properly addressed, had adequate time with their healthcare team, and are confident about what to do next to manage their health. And similarly to our findings in those surveys, a very recent survey from the American Cancer Society Cancer Action Network found that 94% of patients said that their issues and questions were addressed well through their telehealth visit, and 2/3 said that their issues were very well addressed. In that American Cancer Society Cancer Action Network survey, most respondents reported having a phone visit with a telehealth provider on an issue directly related to their cancer care. And I think that there are still opportunities as we move forward in this space to optimize the patient experience, and to what Dr. Kirschenbaum mentioned earlier regarding the very important patient provider relationship, building those relationships as well. And one of those opportunities to optimize the patient experience could be around engaging the caregiver team, which we know is a critical role in both cancer and overall healthcare. Our survey had found that nearly 40% of respondents, they had felt that both in-person and telehealth visits allowed for their support system to be a part of their healthcare conversations. But one thing I think was really interesting about this question that we asked in our survey is that a little over 20% felt that neither in-person or telehealth visits allow for their support system to be a part of their healthcare conversations. So I think this is a really important place as we look to the future of healthcare in general, but also in telehealth as well. And that patient and provider relationship is so critical. And I think there's some real opportunities to continue working on building those personal connections when care is delivered via telehealth. Because in our survey, a little under 50% had reported that they were while they were able to build a personal connection when receiving care in person, they were not able to do that via telehealth. So I think this is a really incredible opportunity to work on that, on those relationships, because those relationships are so critical, especially as we think about that shared decision making. But overall, we're hearing and we're continuing to hear, especially as we are moving through the various waves of data collection in our longitudinal study, that patients are having positive outcomes when they're receiving telehealth.
Rachel, I'd be interested to hear. So in my practice, I have a policy that a new cancer diagnosis should not be done under a virtual in a virtual visit, but rather an in-person visit. Have you guys looked at have you guys looked at that new cancer diagnosis and what patients, what they want?
That's regarding that, the specific to a new diagnosis, that isn't something that we had specifically looked at. But one of the things that CSC has advocated for is that when it comes to that initial visit with a new provider, how there are some of those stipulations that those would have to be done in person, and CSC has advocated for patient choice on that. We don't want that to be a barrier to being able to see a provider for the first time. But regarding the initial visit for a new diagnosis, it's something a really interesting question that you ask. We know that there were number, because of things like delayed screening, we're seeing more of these cancer diagnoses now that people are starting to return a bit more to their routine cancer screenings. And I think that's something for us to continue to look at and gather that data on. We're still in this, in this really critical place where we need to do a lot of research in this space, see patient preferences. So I think that's a really great question.
Yeah, I found that for a second opinion cancer diagnosis, I think the patients are very satisfied with receiving care virtually. But yeah, it's a balance.
Absolutely.
Okay, moving on to our next question. So this is a question for Chris. As we all know, sometimes policy can only move as fast as our policymakers. And so we know sometimes that doesn't move very fast at all until there's some sort of cliff that we're pushing off of. So has the policy world adapted to this fast-paced technology, and what are the top priorities that support the continued use of virtual care?
Thanks, Ray. And as alluded, our policy is far behind our practice. So we've seen many really exciting examples of telehealth utilization. In terms of the congressional or regulatory authority that's needed for Medicare and other markets to use telehealth, we are very much in our infancy. So one way to think about it is we've done everything temporarily, but we haven't necessarily gone back and worked through the details of a policy that would be a permanent, long-standing solution. So lots of flexibilities, not a lot of policy development. There have been a couple places where that's happened, and as Ray mentioned in the beginning, so we've seen some forward movement in behavioral health. I would call that a 2 steps forward, 1 step back situation. But we do have a lot of work on policymaking. So I'm going to do just kind of my dashboard of things that I think about. Not all will be relevant, but I think it's just a good landscape of what it is we are thinking about in telehealth. So in the Medicare reimbursement space, as we've talked about, originating site requirements, geographic restrictions, special payment considerations for federally qualified healthcare centers, rural health clinics, and critical access hospitals to build telehealth. They all have unique billing structures, and then that gets complicated very quickly when you try to overlay telehealth restrictions on top of those. As noted previously, the distance site provider list, so there are limitations on what types of clinicians can bill telehealth. It's not all Medicare enrolled providers. That's kind of silly since there are codes for many types of providers in the Medicare fee schedule that not all those providers can bill telehealth. To my point about behavioral health, so in the end of the year last year, we expanded access to telemental health. However, we also instituted an in-person requirement on it. So you needed to have seen the clinician 6 months prior in person before you could get a mental health visit. We think that is very bad precedent. The potential of telehealth is to create access for people who wouldn't necessarily have access otherwise. So when you put in a restriction that requires someone to have seen the doctor in person, that means that people who wouldn't have been able to see a doctor don't get access to telehealth either. We think that's really unfortunate, particularly in the mental health space where stigma and the challenge of people making that first call and getting that first visit is really important. But I put this out here because this is a real risk for the rest of telehealth too. Telemental health is kind of the first step forward, but is definitely doing some precedent setting for other types of telehealth. So that's something the Alliance for Connected Care is particularly concerned around, the idea that there'd be these in-person requirements. We can talk more about this later. Some of that is concern in Congress that people aren't actually getting telehealth from their doctors, which we have seen disproven in a couple studies lately. So Medicare itself looked and found that 85% of Medicare beneficiaries were getting telehealth from their previous relationship doctors. So it is not this big concern that telehealth companies are showing up and stealing patients. That's just not a thing that's happening. And the risk to those patients who have access issues is far too high to take. As we've discussed here already a little bit, flexibility for audio-only telehealth when appropriate. I would call this policy wrinkle there the distinction between phone and audio only. I would say that our future is going to be some flexibility for audio only, but that audio only be connected to an EHR or other type of digital information system. Telephone visits are pretty hard to track or audit or measure. And so that's an opportunity for fraud that I expect Medicare and others will be concerned about. In the commercial market, I want to flag really quickly, we're working on pre-deductible coverage for people with HSA eligible high deductible health plans. That's something that large employers and health plans have leveraged during the pandemic that has been useful for the employed population and something we'd like to continue. That actually ends at the end of this year if Congress doesn't act. So that's our first way in which Congress could fail, although probably not your top issue. Also in the commercial market area, I want to flag that the Department of Labor had some flexibility around accepted benefits, allowing large employers in particular to offer some limited telehealth benefits to their part-time workers without it counting as health coverage. So lots of large employers use that in order to give their part-time employees some access to care. In the prescribing space, the DEA needs to promulgate a final rule on prescribing controlled substances through telehealth. That's particularly needed for opioid use disorder, but it's something that Congress has been working on for a long time, but the DEA has not yet put into place. And then finally here, I think there's a lot of risk that we end up expanding telehealth in a way that distort markets. So in-person requirements are one of those. But want to make the point as declared by the Task Force on Telehealth and others that telehealth is just a modality. It's not a different kind of care. And it should be a patient and a clinician's choice whether telehealth is the right vehicle for them to deliver that visit. But there is a lot of risk that Congress and others put constraints on it that shape the market. And so advantage some types of healthcare organizations over others, some types of providers over others. We generally don't think that's the right approach. We need to really let patients and their clinicians decide the right path forward. And then the final thing that I just want to stick in here, there are some equity concerns to work through with telehealth. We are seeing that telehealth is more frequently used by the affluent. It's more frequently used by suburban moms than it is people in inner cities. There are lots of challenges to work through there. Some of those are access to broadband services. Some of those are just comfort with telehealth, but that is a real priority that we as a community need to work through. And so that absolutely needs to be part of any kind of long-term telehealth strategy that either the federal agencies or others implement. So I'll stop there.
And I think that's a a fantastic landscape overview of kind of where we are with all the policy. I don't know if any of the panelists want to comment.
Yes, I think that the task force, the American Urological Association Telehealth Task Force, works very in line with much of the policy priorities of the Alliance for Connected Care. And in fact, one of our task force members, Juan Andino, is also a member of the Alliance for Connected Care. So that allows us to dovetail our efforts. And I'd like to just comment on the advocacy efforts that we in the task force have been involved in along these lines. We have specifically been supporting legislation such as the Connect Act, which is legislation that would eliminate the site of service requirements and allow patients to continue to have telehealth from their home, which is only possible because there's a waiver in place. And without the waiver, which exists during the public health emergency, patients would have had to go to a specific location, and only if they came from a qualified area, a rural area. And so we are very excited that the Connect Act eliminates that. Also, we have been advocating for expanded access to broadband, because broadband is required to do these audio-visual telecommunications and telemedical visits. And that is a requirement of being reimbursed for telehealth, is that it's an audio visual telecommunication. However, under the Public Health Emergency Declaration, waivers allow us to use audio only. And when that Public Health Emergency Declaration period ends, that goes away unless there is legislation in place that continues it. So we would love for everyone to have audio-visual telecommunication capabilities. And so we advocate for legislation that would expand broadband implementation, but we also advocate for legislation that would continue to allow for audio only, because we know that until that is achieved, many of our patients rely on audio only because they don't have the ability to have the audio video combined communication, or they don't have the sophistication to engage that platform, and they defer to audio only. We also are engaging directly with CMS. We've had one-on-one conversations with their administrators expressing these goals, the goals of the site of service, preserving this past the public health emergency, the goal of preserving audio only until broadband is accomplished, or just preserving audio only long-term because it is a very effective form of communication. Also, we advocate for allowing telemedical supervision of our residents, therefore allowing greater access to patients who are serviced by residents rather than requiring the arrival of the attending physician in person. So facilitating the care and decreasing the suffering of patients utilizing telemedicine supervision. We have met with the Government Accounting Agency, expressing the rationale for continuing to allow telemedicine to occur in its more liberalized and unrestricted way past the public health emergency. And we've understood from them where the agencies can weigh in and the limits of what they can and cannot do, and where legislators really have to weigh in. And the great thing is that all of these conversations we've had with the agencies and with legislators have positioned us to be able to be an important source of information for them in helping to shape how they understand how telehealth is going and what our goals for it are in the future. we have been able to provide data that our members have been able to generate about the utilization of telehealth with audio video, with audio only, what the demographics are of the people who are utilizing it, inner city, rural areas, suburban. And we've been able to make a very strong case that what we are doing with telehealth is high quality for the patient, preserving access or even increasing access. And we've gotten really positive feedback. So I'm very excited and confident that the role we've been playing as the Telehealth Task Force for the American Urological Association is in fact planting a strong foundation, a positive foundation that the administrators and the legislators are considering and are incorporating. And I do think that we are affecting the formation of policy going forward. And it's so critical because once the public health emergency declaration ends, all of this access goes away if it is not otherwise legislated.
So, Dr. Spitz, you actually answered the next slide, which was geared towards you. So I appreciate that. And kudos to Kim Nelson and Adina Lasser for putting this together so well that it just flows together. So I'm going to move us along just because I know we're running short on time. So the next question goes back to Chris. Now that we've kind of laid out the landscape, what does it look like moving forward here? What are the policies that you think are the most promising? And I know we talked earlier about, there's the bills that are out there, but it's actually the individual pieces of policy that's probably going to make its way into the future. What is that path, knowing that the public health emergency is probably going to get extended? And then similarly, what are the challenges with CMS? Because we know as a regulator, they have some authority here that they could advance without legislative backing. And, what could they do to kind of help us facilitate better telehealth engagement?
Thank you. And sorry, I was a little bit of a wet blanket earlier. I do think we are making forward progress on telehealth policy. It's just we are much earlier in the process than we'd like to be. And so I think the data collection and the evidence and the stories are all incredibly important because we are very much still in the early stages of policy development, even though it feels like we've been doing this for a very long time already. As Ray had mentioned, there are a couple big legislative vehicles that have bicameral support. The Connect for Health Act, which is Senator Schatz's bill, which has the support of the Telehealth Caucus in the House as well. The Protecting Rural Telehealth Act, which is Senator Manchin's telehealth package, which is also introduced in both the House and the Senate, and Energy and Commerce and Ways and Means, that has, as you might expect, a little bit more of a rural and audio only bent to it. But has similar provisions around geographic and originating site, rural providers, and other elements. And finally, the Telehealth Modernization Act is the other kind of big umbrella bill. But as Ray mentioned, we're probably going to see something completely different from one of these bills finally pass. That's not to say the bills aren't important. They are very important. They're a signal of what needs to happen. They all have similar components though, and those components are what are going to make it into probably some big omnibus piece of legislation at some point. And so we've already talked about geographic and originating site. We've talked about some flexibility for FQHCs, RHCs, and critical access hospitals. We have ideally talked about some kind of provider flexibility that is a little more tenuous. We would love to see the in-person visit requirements repealed. That is also a little more tenuous. But to kind of bring that home, what I think the more likely scenario right now is the Alliance for Connected Care has been working on a clean 2-year extension bill to try to just give some certainty as to what's happening in telehealth, put some really clear research and evidence requirements out there. So at the end of 2 years, we know exactly what we're making decisions based on. But we need that predictability for everybody to make the investments and put the time into doing telehealth. So, because there's a difference between doing telehealth on an emergency basis and putting in place the systems and technologies to do it on a long-term basis, which some healthcare providers have done, but not all have. And so really need that predictability. We think 2 years is the right way to do that. And we also think that's the best we're actually going to get from Congress. Sorry to be a wet blanket again. Congress isn't quite ready to do permanent telehealth. They have concerns about cost, quality. There are some concerns around fraud, although those are mostly not very legitimate. What actually happens in this space is telemarketers pretend to be clinicians and bill fraudulent DME claims, which isn't telehealth. And we remind everybody of that every chance we get. But there are some concerns about how the system could be exploited. And that's why a temporary approach where we can look back and see what happened and see if we successfully addressed equitable access to telehealth and made sure that the people who need the care are getting it is kind of the way forward, I think. So working hard on that. We do expect that the public health emergency is going to get continued as COVID hasn't disappeared yet. And because there are political implications of ending it. And that also takes some of the fire out of Congress, right? So if Congress, to Ray's point, has a deadline, they feel like they have to act, knowing that the public health emergency isn't quite over, they don't feel like they have to act. But that is an unfortunate situation for patients and clinicians who are left waiting and watching to see what's going to happen. And then finally, just to wrap up here, there are some things that could be done with a regulatory authority. Much of the regulatory changes that have happened have been under an emergency basis, under a National Emergency Act powers, but there are things that we're pushing for CMS to do that they can do on their own. Some things like provider location requirements in Medicare. So as it stands right now, a clinician is required to report their location of practice. So if you're practicing telehealth from your home, you're required to publicly submit your home address to the Medicare program. We don't think that's a great situation for a lot of clinicians who might not want to list their home address publicly. There would be opportunities to strengthen direct supervision, which we've talked about before, permanently. That's something that they could do. And I think we've seen a lot of evidence around how that is an opportunity to expand the capabilities of our healthcare workforce. CMS can do a better job of alignment across programs, so different rules and different programs, be it value-based care programs, alternative payment programs, different types of provider programs, alignment with the commercial market. I think there's a lot of opportunity to try to simplify things because there's so much variation between different payment programs and structures. There's a lot of work like that that could be done here in the telehealth space that hasn't really yet. So I'm going to stop there.
Chris, just a quick question. So, Dr. Spitz and I were talking last night how for example, the Zika public health emergency is still in place. Do you see a scenario that this public health emergency just gets getting kicked down for years and years and years, and Congress never really acts, at least in the next few years?
Hypothetically, this is a much bigger and more expensive one. But if you think about how this goes forward, so if it continues into early next year, we come into next summer where we're facing an election cycle. Is President Biden going to want to end the public health emergency and turn telehealth off before an election cycle if Congress hasn't acted? Those are mostly political considerations. But on the other hand, the COVID public health emergency has been a much bigger and much more expensive public health emergency than some of the others. It's a lot more than just a few waivers. It is significant expenditures by the federal government. And also, to our point before, it is actually not great to continue to do a lot of these things on an interim basis because we're providing care based on a waiver of regulations rather than any types of guardrails on patient safety, et cetera. Lots of those things are just temporarily gone rather than amended for telehealth. And really the right way to do this is to create new policy and move forward in a way that recognizes what risks do exist in this space. But we're not quite ready for that. But it is legitimately quite feasible that we still have a public health emergency a year from now. But don't tell Congress. Congress needs to believe it's like ending right away.
Very helpful. If we move on to our next slide, I'm actually going to skip Dr. Spitz, the question we had for you on data, because I think you covered that just for the sake of time, and go over to Dr. Kirschenbaum. So this kind of goes to some of what we discussed about what's happening in the states. How is sunsetting with the state health emergencies, affecting urologists for insurance that is regulated by the state? And then similarly, are urologists then shifting away from telehealth usage because of the lack of reimbursement? What are you seeing out there with your colleagues? What are you hearing?
Yeah, so I think there's a serious concern about sunsetting. We're in this transition period where public health emergencies are expiring at the state level and new bills are being introduced. Some are being passed, some are not being passed. And I think the biggest concern is that urologists are going to be confused. When urologists don't know if they're going to be paid for a service, they're going to quickly not offer that service. So I think one thing that we need to do as an organization is and what the AUA is doing a tremendous job is continuing to educate our members on what insurances do cover, what is Medicare doing, so that we stay on top of that. But it is absolutely a concern, and we have to work both on a state and federal level to make sure that the services that we're offering are being covered. So a state like Illinois, there's been a lot of there's the opposite of sunsetting. We've expanded our telehealth coverage recently with a bill, a parity bill into 2027. But then you look at a state like Florida, where they let their PHE expire, and now non-Medicare patients no longer are able to get audio only. So it's a complicated process because each state, because it's being done on a state level, but we got to legislate on and advocate both on the state and federal level. In terms of what urologists are doing, if they're shifting their practices based on a lack of reimbursement, I think that data is not there yet. I think we saw a significant increase utilization of telemedicine with the pandemic, and as patients started to come back to the clinic, we saw an expected decrease. But I'm not sure that we know how urologists are reacting. I don't think it's just not mature because these bills are currently being passed. I don't think the data is there yet, whether urologists are really not continuing their telehealth practice. In my practice of kind of my small 5-group practice, I would say that a lot of urologists, that half of us have stopped using telehealth because they just don't know what's going to be reimbursed. Are they going to do this? Are they going to expand their telehealth services? And then Congress the next year is going to say, actually, you can't do that. So a lot of questions, a lot of advocating to do going forward for urologists.
So if we go to the next slide, this kind of dovetails into that, to the other side of this from the patient perspective. Rachel, we just talked about all these different policies, both the state and the federal level. We're talking about, sunsetting with a lot of these public health emergencies have been declared. What impact are you seeing from the patient community, on their ability to access care? And then because of the sunsetting and the law and kind of the confusion around what's available, are you seeing patients kind of going away from seeking telehealth care and trying to go back into in-person, or what else are you seeing?
That's a great question. And similar to what Dr. Kirschenbaum mentioned about the confusion that that this is causing for providers as the emergency waivers are ending in many states, so those flexibilities are also expiring. This also creates a lot of confusion for patients. One being that many patients didn't know about the temporary flexibilities to begin with. It's also creating disruptions in continuity of care, which of course is critical to ensuring patients' health and well-being. Any delays or disruptions to care can really threaten health outcomes for patients. And the expansion of telehealth during the pandemic is, of course, to help continue continuity of care. But for patients that may have been, the past year, seeing a provider that was in a different state, they've been seeing them for a year, and then receiving notification that they can no longer access that care via telehealth, that creates a lot of confusions, a lot of questions about what comes next in someone's cancer care or even for general medicine. So it's really important that states act to ensure that these flexibilities continue, especially as we've been continuing to learn a lot of lessons from the public health emergency, and make sure that the policies and practices are in place to prevent future gaps in care. For the people that have been accessing care across state lines via telehealth, we know that patients do that for a variety of reasons, and those licensure flexibilities have been really critical for expanding patient access to care, and of course, improving care coordination, continuity of care. I know that we've seen some reporting that patients have driven across state lines, then taken a telehealth appointment from their car to be able to continue accessing their telehealth appointments. And so, of course, we know that states are looking at the ways to expand telehealth and other services. One place that where we've seen telehealth, how telehealth can be utilized, and again, thinking towards the future, is in clinical trials, and how telehealth has, during the pandemic, has been utilized in trials. I know I hope that we see that expanded usage of telehealth in cancer clinical trials, because telehealth can help to advance decentralized trials in oncology, because access to clinical trials, including cancer clinical trials, can often be limited for patients living in rural areas, and travel and lodging, of course, can be very expensive, even for those patients that aren't traveling long distances. Just the additional time requirements can be a barrier to clinical trial participation. And so telehealth can be really used to enable access to clinical trials, and by assisting in trial eligibility, consent, participation, follow-up. So what we've been hearing from patients, we know, of course, early on 2020, nearly 80% of patients that we had surveyed in our COVID and cancer patient survey had engaged in telehealth. And because our survey is looking at longitudinal data, we have been able to see that, despite relaxing of COVID-related restrictions and the returning option for in-person healthcare, that people are still accessing telehealth and telemental health services. It does appear to be at a lower level than at the very height of the pandemic, of course. But our recent data from our longitudinal study has found that in the respondents that had indicated that they had utilized telehealth in 2020, over half of those patients have still engaged in telehealth within the last 3 months. And actually, in talking to some people, some physicians I've heard are still doing only telehealth appointments. I spoke recently to a cancer survivor who was overdue for a routine colonoscopy, and their gastroenterologist was only offering telehealth appointments. And so they were able to, of course, have their appointments. It only took 30 minutes for them. They didn't have to take off much work, worry about parking, transportation, and were able to speak with them about their need for cancer screening, and was able to schedule a colonoscopy on that call. And I know earlier on, in talking about the pandemic's continued impact on psychosocial health, the burden is still really great for people with cancer. And virtual support groups, including those offered through CSC's affiliate network, it can be a really big part of a patient support system. And so continued telemental health care is necessary to continue to support patients through a cancer diagnosis. We saw in our survey, looking at the various waves of data collection, we've seen an uptick in the percentage of people who are utilizing telemedicine for mental health services. And again, just in talking with people, I've had people tell me that now that they've been receiving their mental health care via telemental health services, that they never want to go back to in-person care for their mental health care. Because as we've been discussing, the future of healthcare will be a mix of that in-person and virtual healthcare. Not all appointment types will be suitable for telehealth, of course, but many components of care can still be performed by telehealth.
Yeah, that's fantastic. And I think one of the things you said in there kind of leads us to our next slide, which is actually about the interstate medical licensure compacts. And so this one's for Chris. What is the interstate medical licensure compact and why is it important for expanding access to virtual care?
Thank you so much. I want to say one other thing first. And Rachel Solomon touched on utilization, and I want to emphasize that the idea that patients are going back to in-person care is good for telehealth. It is not bad. We occasionally have this narrative, like in the press, of like telehealth utilization is declining. Does this mean the boomlet's over? And that is not the case. So one of the biggest challenges that we have in expanding Medicare telehealth is the perception that it's going to lead to additional costs to the Medicare program, that like somehow there'll be a much greater utilization because telehealth exists. All of the Alliance for Connected Care or member health systems have pulled together kind of utilization charts where they show the mix of in-person and virtual services, and they show that there is an inverse relationship. When their in-person services go down, their telehealth services go up. When their telehealth services go down, their in-person services go up. That is how it should be, because that means that patients and clinicians are deciding to take visits that they needed to have either way, and deciding the modality on which to have them. And so I think it's good that telehealth visits go down as places feel like they're recovering from the pandemic. The important thing is that the option remains when needed. So then to shift to licensure. So as you guys probably know, all 50 states in some way or another waived medical licensure requirements, allowing clinicians to practice across state lines during the pandemic. Some of them used like a registration process. Some of them just did a waiver. Lots of different ways it was done, but all did it. And it created a lot of opportunity for, say, clinicians to focus their efforts when there were surges in places like New York, and there were suddenly capacity issues that COVID created that weren't able to be handled. However, has had many other amazing opportunities. We talked about specialty care and cancer care, people being able to do telehealth visits with centers of excellence that they otherwise would have had to travel to. So, we have Stanford or Johns Hopkins in our membership. We have people that would have traveled across the country to go to those places, but are now able to manage their relationship through telehealth across state lines, which has been terrific during the pandemic. And it's something that we need to hold on to beyond. However, many of those temporary flexibilities are lapsing and going away now, and we're going back to our older structure. I do want to flag that we recently worked with AUA on a letter to all 50 state governors asking them to hold on to these flexibilities until the public health emergency is over. Some states may do that, not all of them will. But when we have to go back to the structure, well, we shouldn't go back to the structure we had before, which is separate licensure, medical licensure in all 50 states. Right now, we do have an interstate medical licensure compact. It facilitates it coordinates between states, is what I would say, to facilitate licensure in multiple states, but it does not reduce the burden or the costs of maintaining medical licensure in many states. So what that ends up doing is it means that large organizations with lots of resources pay staff to manage their clinicians' licensure in many states so that they can practice. Small organizations get significantly disadvantaged in that situation. Obviously, there does still need to be a medical board oversight structure where we watch for patient safety issues and manage the profession. But there should be opportunities to move forward in more of a mutual recognition type structure where states acknowledge each other's governance of clinician and allow some additional clinicians to practice across state lines. So that's something that we're working on in many different ways. And I don't think we need to get into in too much detail, but I think is another thing that's been exposed during the pandemic, which is tangential to telehealth, and it's a big opportunity for healthcare to say better meet the needs of people in areas where there are clinician shortages, or the many cities in the country where there's like a state dividing line down the middle of a metropolitan area. Kind of silly that we have licensure challenges in places like that. And so hopefully that's something that we can also take away from the pandemic as an opportunity to improve healthcare.
Fantastic. So I'm going to skip us forward a little bit because we are running out of time, and actually combine some of these questions together. I think we've touched on a lot of what we were going to talk about before through the course of our conversation. But what I really want to get at here is, there are resources out there. I think this group represents a number of organizations that has resources available. So first off, what are those resources? And then, similarly, how are we going to get the patients and providers together urging action on telehealth legislation, policies, or what have you? And I would open this up to the entire panel, really, because I think everybody might have something to say about this.
Well, the Telehealth Task Force engaged patient and patient groups directly with a call to action to support the CONNECT Act earlier in the year. And we also engaged our urology members as well. So this is grassroots activism, directly contacting legislators' office about a particular bill. And as other bills come online that are favorable to telehealth, we can continue to call to action these kinds of grassroots activities at a national level, but also at a state level. And we have a state society network that can be mobilized to reach out in a grassroots way to local urologists and local patients and local patient advocacy groups with regards to state legislation. So this kind of grassroots activism and mobilization is one of the ways in which we can urge action on telehealth legislation.
I'd love to piggyback after what Dr. Spitz had mentioned regarding grassroots advocacy, because I completely agree. I think it's really important that policymakers hear from patients, providers, caregivers, families about why telehealth is so important and about why these flexibilities need to be made permanent. And as part of that, I think one thing that we've been looking to, that we'll be continuing to do, is storytelling, because being able to capture those stories from patients and providers about how telehealth has been invaluable during the pandemic, and making sure that those stories are captured and shared with members of Congress, on state legislators, CMS. And similar to what the various panelists have been talking about, there are a lot of bills out there. So being able to coalesce around some of these bills are really critical. And then there's a number of organizations, patient and provider organizations, including those on today's panel, that are working on these issues. So I know at CSE we've found that working with coalitions is a really great way to urge action on these policies and this legislation by coming together with that collective voice. I know, at CSE, we've partnered with the AUA-run Prostate Cancer Impact Alliance to look closely at this issue, and also look at various awareness initiatives. This fall, we partnered with the American Telemedicine Association for the first annual Telehealth Awareness Week. So I think there's a number of ways for patients, providers, patient advocates to be engaged on this issue. And I'd be happy if anyone would be interested about the work that we're doing, or how our storytelling campaign. I would definitely encourage people to reach out, because it's really important that we come together. We all have the same goal, so to come together with a really loud collective voice on this issue.
The only thing that I would add would be the AUA policy summit in March would be another, another place where we could really advocate, where urologists and organizations are coming together to advocate for some of these policies that are so important to us. So I think that's in March coming up in DC.
And I'd just like to share that you guys have done a pretty good job talking to Congress about the need for telehealth. I'll share with you that some Hill staffers are like, please have the doctors stop calling us. We know we have to do telehealth, which is great. But I think the thing that we can do that also makes the most difference is data collection and research. So to the extent that we're looking at utilization data, we're understanding cost and quality. Those are the things that are going to really help us get over the final finish line for this. In addition to patient stories and kind of an understanding of the opportunity going forward. So agree with what others said.
And so I'm going to move to the next slide because we have a lot of great questions. I want to get to them, but final thoughts. Where do we go? Where does telehealth go from here? Any kind of parting comments? And I'll start with you, Chris.
I think I might have just kind of said it, but but yeah, I think we have a path ahead of us, but it is mostly collecting evidence and understanding what our path is forward. Hopefully, we don't have more hiccups or any steps back on the way, but I do want to emphasize for people that the conventional wisdom that telehealth is here to stay is not baked. And I think lots of healthcare trade press treats it like they'll never take away a benefit in Medicare that they added. But that is definitely not true. Or if they do, there's a pretty significant risk that it gets added with some really painful guardrails that make it difficult to use and challenging. So I do want to just emphasize that the need for advocacy is very much not over. And thanks to everybody for being so engaged.
I completely agree with Chris, what you said regarding the data collection. I think a lot more data needs to be collected and more research needs to be conducted on the usage and the outcomes of telehealth. And I think with a special attention to promoting health equity in order to determine how telehealth technologies should be designed and implemented so that all populations have equal access, because advancing health equity using telehealth will require a combined effort to expand coverage of telehealth and telemental health services, close that digital divide. And I'm really happy to see some, the attention on advancing access to broadband, because that is critical to closing that digital divide, but then also break down other barriers that may prevent people from receiving healthcare virtually.
Yeah, so telehealth is just beginning. There is going to be an incredible evolution over the coming years. I'm confident that it's not going to be rescinded at the end of the public health emergency. There's going to be some amazing technological advances that get rolled into it, including artificial intelligence, which will also be very interesting when combined with asynchronous healthcare, which is where a patient can pose a question, a doctor can reply with an answer, and then there can be this sort of on-demand answers and implementation of healthcare. And then you combine that with a Watson-type AI, and the democratization of healthcare will be pretty tremendous. But there's going to be a lot of challenges. There'll be challenges to patients' access to it. There'll be challenges to providers' ability to adapt to it or to guide it or to keep it safe. But there will be a tremendous revolution coming. We've seen that in so many other aspects of our commercial life and also of our private lives. And there's no reason that this won't happen in healthcare. But being out in front of it is key so that it happens in a way that makes sense and that is safe and that is sound. We have a telehealth community for our members online called Telehealth Connect, where we can ask each other questions, we can propose solutions, we can philosophize, we can talk about data collection, and even invite people to participate in studies. And so I would strongly encourage all of our physician members to take a look at the Telehealth Connect community that the AUA curates and get more engaged, and we can sort of forge this new, very exciting path together in a way that makes the most sense for our patients and for us providers.
And just finally, a couple parting words. I think we'll see just a continued improvement in the patient experience, where they can seamlessly go from their phone or the computer in their home into the medical office, into the operating room seamlessly, and not having to piecemeal together their virtual experience, where it's a nice, smooth transition, which optimizes their outcomes in care while still kind of maintaining that evidence-based practice in medicine.
Great. Well, I really appreciate all of that information. And we do have a number of questions. I know we're really short on time, so I'm going to try to squeeze a few in here. So that first question we have is for Rachel. How can telehealth help achieve health equity? And I know that's like an overarching huge question, but I'm hoping perhaps you have an answer for us.
I guess really quickly, that combined effort, one being closing the digital divide is really critical, because we've seen data just from this year about the disparities in who has home access to broadband. Some of the statistics are pretty startling. So working on closing that digital divide, because we've heard that someone without being able to have that home broadband cannot be a full participant in today's society, because we've seen it's being needed for healthcare, school, work. So closing that, breaking down those other barriers that we've seen, making sure the audio only continues, because as the other panelists have talked about, that has been really critical for people that may be unfamiliar with the technology, lack the broadband, have disabilities. So it's going to require a combined effort, and then also working to advance those policies so that those flexibilities are made permanent.
Yeah, appreciate that. This next question is actually for Dr. Kirschenbaum, Dr. Spitz. Could you please comment on store forward or synchronous use of remote urotechnology, diagnostic cystoscopy, et cetera, using on-site physician extenders or other medical professionals?
Sure. So store and forward technology allows the physician to review data when they are able to get to it. It may not be at the same time that it's being accumulated. Now, that data might be questions that are being answered about health history, or it might be images of the inside of the bladder from a cystoscopy. And so this has been implemented at Kaiser Permanente. In some locations, they've had advanced practice practitioners be able to perform cystoscopies, and then the urologist review the images later and confirm if it's benign or not, and then be able to direct care from there. A great example of asynchronous technology in the commercial sphere is HIMSS and Roman's platforms, where there's questionnaires about sexual health history, and then this is reviewed by a physician who then can determine if it's safe to prescribe medication such as sildenafil. Remote supervision, on the other hand, is real time. It's not asynchronous, but it allows a urologist to care for patients in other locations where he can't or she can't physically be, but where an extender may be, a nurse practitioner, PA, a nurse, performing an examination, conveying information back to the urologist, who can then direct patient care without either of those, patient or provider, having to be in that same location. And it really expands the reach of the doctor to provide care through his extenders or her extenders remotely. And these are all elements that we are trying to preserve. The supervision component, we're really trying to preserve that even down to the level of trainees to residents for the same reasons mentioned.
Yeah, I don't think it's a question of if it's going to happen, but more a question is when it's going to happen. And I think urology is ripe for it to be the leaders for a couple of reasons. There's urology is one of the oldest specialties. We're having urologists retire at a rate that's going to create a significant physician shortage. So I think if we're able to optimize the time of the urologist by using technology like store and forward technologies, I think that's a natural solution to some of the physician shortage issues that are on the horizon. So I think it's going to happen. It'll take some time, but I do see it coming.
Fantastic. Thank you both. So last question, since we're really past our time, and I appreciate all staying on just a little bit extra. And so this is for Chris. In regards to how telehealth has improved patient care, how do legislators and their staff respond to the types of stories and evidence that you've provided, that Rachel's provided? And then, telehealth fraud, waste, and abuse seems to be a major concern from the government bodies, from CMS essentially. What kind of data do we collect to buffer those fears, or what could we provide to CMS to help buffer that? And that might be a question the rest of the panel might also want to respond to.
That's a terrific question. First of all, I think everyone likes telehealth. Everyone tells you they love telehealth. The question, as you've alluded to here, is how do they feel about what steps need to be taken to expand telehealth? So do they have concerns around fraud or cost or well, they're kind of the same thing, really. It's for Congress, it's all about the money, right? As I alluded to earlier, I think some of the concerns about fraud have been misperceptions, such as the idea that some of the instances of DME fraud that we've seen perpetrated through telemarketing are telehealth. I mean, it is healthcare and it is frequently over a phone or a remote connection, but it is not telehealth. We've seen almost no telehealth service fraud. We have seen some fraudulent actors try to exploit telehealth to do other types of fraud. And so we've worked through recommendations such as solicitation restrictions or other types of things that would prevent, say, bad actors from entering the system. There's also probably opportunities to strengthen Medicare provider enrollment because there aren't a bunch of doctors out there committing telehealth fraud. Like that is pretty much a fact. And we've seen a slew of reports come out of the Office of the Inspector General at HHS that for the most part validate that. They're seeing instances where people misbilled because telehealth is complicated. And they've seen instances of these kind of telemarketing thing, but they haven't seen telehealth service fraud. And that's something that we need to make sure everybody really recognizes, because there is kind of this self-reinforcing conversation around fraud with very little evidence to back it up. And that's one of our reasons that we keep talking about evidence, because in the absence of evidence, you have rhetoric. When you have evidence, you have evidence. So I'll stop there.
Okay, well, if nobody else has a comment, I want to thank all of our panelists. You all have been fantastic. I really appreciate you being on for the last hour and a half, especially for those of us in California, where it was 6 a.m. when we started. So thank you all so much. Really appreciate it. Love working with you. If we have any other questions, we'll pass it along. Again, thank you very much. This will be recorded for all of our participants who came with us today. We post it onto our website and also share with all our panelists if you would like to share as well. Thank you.
Thank you.
Thanks for everybody tuning in. Really appreciate it.